Then let us also look at oligohydromnious. By definition, this is abnormally small amounts of amniotic fluid, less than 500 ml, but it may be as little as 60 ml. So the amount may be between 300 and 500 for the commonest oligohydromnious seen. We have said that normal mils in normal pregnancy is around, it diminishes from 1 liter to around 800 mils. So polyhydromnious, it shall go and exceed up to around 1,500 mils. So for oligo, it is coming below 800 mils, and it can be detected between 300 to 500, or it can even go as less as 60 mils. Causes are fetal anomalies, like we've said, even in polyhydromnious, that is obstruction of urinary tract and renal agenesis. Like we said, the key component of amniotic fluid is fetal urine. Then placental abnormalities, that is, the placenta fails to secrete amniotic fluid. Like in the beginning, we looked at the general mechanism of the amniotic fluid, that it is the placental cells and the amniotic membrane cells which produce amniotic fluid. So there can be a condition called amnion nodosum, which is failure of secretion of amniotic fluid by the cells of the amnion covering the placenta. The condition is called amnion nodosum. Then fetal chromosomal anomalies like trisomy, intrauterine growth restriction associated with placental insufficiency. Here it means our baby may not be feeding very well, therefore not producing enough urine. Then there can be rupture of membranes. This may be a gush of fluid or slow constant trickle of fluid, which can be due to a tear in membranes. So these membranes can rupture at one time, or they can try to leak slowly by slowly, like we've said. Then post-maturity, that is over 42 weeks, which could be as a result of declining placental function. Remember, by term, the placenta may start to deteriorate in function. So if this mother goes post-gestation, the placenta may cease to produce amniotic fluid, and this can be one of the causes of oligohydromnious and twin-to-twin transfusion. So what may be the maternal complication? One is maternal dehydration, hypertension, preeclampsia, DM, chronic hypoxia, which can have an effect on amniotic fluid levels. Signs and symptoms. 1. On history taking, the mother will complain of loss of weight, and she will report reduced fetal movements. On abdominal examination during inspection, the fundus will appear smaller than expected period of gestation. Remember, in poly, the fundus looked greater than the expected weeks of amenorrhea. This time in oligo, the fundus will look smaller. The skin will look dry and tough in appearance. The abdomen will appear smaller on each antenatal visit. No fetal movements will be seen. And on abdominal palpation, of course, the fundal height is small compared to the weeks of amenorrhea. Malposition and malpresentation may be felt as the fetus cannot rotate in order to correct its position and presentation. Remember, in utero, for the normal liquor, the fetus moves comfortably, and at the end of the day it will find that the head is down. But because there is no liquor, this fetus can fail to take on the right position and presentation. So on palpation, because there is very little liquor, the fetal parts can be palpated very easily. But on balloting, the fetus will be unable to ballot. Ballot is getting like on the head and you feel the head moving from hand to hand while you are palpating the abdomen. So it will be hard for the fetus to be ballotable, but the fetal parts can be very easily palpable because there is very little water on the fetus. And on auscultation, the fetal heart can be felt. Good. So what do we do? Management. History taking is done. You take the particulars, you ask the mother when she last felt the frequent fetal movement. This mother will tell you. So on observation, you assess the condition of the mother and decide on the management by taking the blood pressure, pulse, respiration, etc., plus the fetal heart. Continue with general examination to rule out anemia, jaundice, organomegaly, that is the spleen and the liver, and signs of dehydration. Then on general examination, determine the weeks of amenorrhea and the condition of fetus. And also go ahead to note whether there is any contractions. Assess signs of maternal dehydration, and if the mother is dehydrated, offer some rehydration orals or IV, and this may in turn help to increase on the amniotic fluid levels. Write a referral note and refer to hospital. So when this mother reaches hospital, of course, tests like non-stress tests will be done in order to rule out the cause of oligohydromnious. Examination whether this mother is having any contractions may be done, and if there is any contractions, monitor the baby's activities. If this mother is to full term, go ahead to carry out the first, second, and third stage. Complications of oligohydromnious is fetal, of deformities of the lower limbs due to, like tallips, due to pressure and compression of the fetus, adhesions between the fetus and the membranes. We can also have congenital absence of the kidney. All this can be seen. So in brief, that is oligohydromnious. So another amniotic fluid disorder can happen in normal amniotic fluid, but when we have the premature rupture of membranes. Preterm or premature rupture of membranes is the rupture of membranes during pregnancy before 37 weeks of gestation. Here the mother is having normal liquor, not poly, not oligo. But before 37 weeks of gestation, the membranes rupture. Usually they rupture before even the mother has labor contractions. So they are saying that premature rupture of membranes can lead to perinatal morbidity, that is death of the baby, and other complications like respiratory distress syndrome, neonatal sepsis, umbilical cord prolapse, subplacental abruption, or even fetal death. So appropriate evaluation and management are important for improving neonatal outcomes. So what do we do? When the mother reports premature rupture of membranes before 37 weeks of gestation, we should, as much as possible, desist from making a vaginal examination. So a speculum examination is preferred, and here we shall determine and look at the cervix and see whether it is dilated. And here our main aim is to prevent irritating the cervix for this mother to start labor. We would like, as much as possible, to prolong the onset of labor. So, when we talk of premature rupture of membranes, what may be the classification? We have said there is what we call premature rupture when the fetal membranes rupture early, at least 1 hour before labor has started. Then prolonged rupture of membranes. This is the case of premature rupture of membranes in which more than 24 hours has passed between the rupture and the onset of labor. 24 hours, that is about a day. Then there is what we call preterm rupture of membranes. This is when the rupture of membranes occurs before 37 weeks of gestation. Here we don't know when labor may start. So we have the 3 terms: preterm, prolonged, and premature, which will be defined in terms of time before labor begins. What brings about premature rupture of membranes? One is weakened fetal membranes. So we are saying fetal membranes are likely to break because they may become weak and fragile. This weakening is a normal process that typically happens at term as the body prepares for labor and delivery. But this can be a problem when it occurs preterm, that is before 37 weeks of gestation. The natural weakening of fetal membranes is thought to be due to one or a combination of the following. 1, cell death. That cells can go programmed cell death, and they release chemical mediators that are detected in higher concentration, causing pre-prom. Poor assembly of collagen, and collagen is a molecule that gives fetal membranes their strength. So in cases of pre-prom, proteins that bind and cross-link to collagen to increase its tensile strength are altered. Therefore, the strength of fetal membranes will decrease. Infections and inflammation likely to explain why membranes break earlier than they are supposed. We have sexually transmitted infections, etc. They can also lead to premature rupture of membranes. So what are the risk factors? What are the people who may face this? Those are the people who smoke cigarettes, who are having sexually transmitted diseases, who are reporting a history of preterm labor, who had vaginal bleeding or uterine distension like